We are actually very honored to actually have two very good guests today to talk about what I think is an interesting topic, which is pretty much personal health information and really the life cycle of data, like what happens to it. On one side of me virtually is Fred McClimans. He's a tech and equity analyst at Futurum Research. Hey, Fred. And then Matthew Thode, who is the director of IT service delivery at Mindsight. Hey, Matthew.
Good morning. Good morning.
So I want to get into it since we kind of have a limited time. When we talk about personal health information and data ownership, this is a topic that, I think I was just telling you all recently that there is a ProPublica article that came about how data is being bought, sold, and traded, and people's de-identified data is being re-identified almost on an industrial basis. When we think about it, though, how is that data typically transferred or handed off in networks and clinics? Because as a patient or as a doctor, really, the only interfaces I see are an electronic health record, or if I'm the patient, a person, maybe my phone if I'm really up on things with Apple. But what happens to that data and how is it transferred? Fred, can we start with you?
Yeah, absolutely. That's a really good question to kind of kick off with here, because everything that we're going to talk about today, it all starts with data. It starts with a patient. It starts with a healthcare provider. It starts with a clinical trial or a pharmaceutical company or a lab. And the reality today is that if you look back, the way data used to be captured, it was very secure. You had a doctor's written notes. You had a piece of paper with a prescription. You had all the medical records that sat in one massive file cabinet that existed. It was immutable. It was never going to change. You could go from doctor to doctor. It would just be inherited. Today, it's a completely different world. The challenge that I think is important to kind of point out up front is that we don't really know where all that data begins.
Right.
That's a challenge for many. But I mean, typically within a local provider, a local doctor's office, they've done a pretty good job of pulling together the necessary systems. They've got the PDA that walks with them from room to room. They're capturing the data. They've got the laptop, in the hall. They can, add notes. They can write a prescription. They can handle all of that relatively, tightly inside that organization. So I think from that standpoint, the data really hasn't changed that much. The processes really haven't changed. We've just taken the paper system, we've put it into a digital system, just kind of swapping out one tech for another tech. With that, it's when you start to get into that larger picture where the doctor now communicates with 3 or 4 pharmacies, or maybe 3 or 4 dozen pharmacies. They've got calls that go to another physician's office. They've got calls that go to a specialist. They are handing out certain bits of information to patients through online portals. Once you get into that mode, we really don't know what's secure and what's not, and where it goes is somewhat of a mystery. I mean, that's my take.
No, it's a scary take, but it sounds fairly accurate.
So I think it's. I'm sorry to interrupt. Yes,
no worries, please.
I think what's interesting is, regulatorily speaking, the controls that providers have on the data is actually still fairly tight. I mean, yes, there's certainly opportunities for data loss or, malicious access of data. I think where you're really seeing a lot of spread of data and aggregate of data is at the payer level. So, you can read any number of articles about how insurance companies, payers, they're stripping the personally identifiable information, but they're building profiles on patients using aggregate data. So they're building profiles on people to know, hey, how do we charge this person? What health, what potential health issues is this person going to experience in their life? And that data can be essentially applied against other patients. So to me, when I go to the doctor, I'm not so much worried that, some bad guy in Romania is going to see the result of my last CAT scan. I'm really more worried about that my insurance company is going to raise my rates based on some type of big data analysis that maybe I'm not even aware of.
Well, Matthew, that's a great point there, because the ability to share data, it's become frictionless. I can't tell you how many times I've heard stories and experienced myself where you provide a piece of data and it gets lost in the mix. The provider doesn't know where it is, or the doctor says, we sent that. I know we sent it, but we're not sure where it arrived on the other end. So there's a sort of a human element that creeps in there, with that. But that sharing of data, the ability to create, aggregated data that provides a complete picture that, literally unmasks the mask, in this whole scenario here. That is incredibly troublesome. And that's one of the concerns that a lot of patients have, and a lot of the clients that I deal with, they're very concerned about doing anything within the healthcare space because of the risks involved in that. It's not just knowing what data you have, and a lot of organizations, they don't know what data they have. We talk about, shadow IT, where somebody brings their own phone into the office, but there's also shadow data. There's shadow clouds that exist out there, little pockets, as the providers and all the ecosystem around them have kind of grown up. So a huge concern in that particular area there. I think that there definitely needs to be a bit more disclosure, and I think probably a more stringent application of what data can be masked, what data can be used when it's masked, because the reality is the tech now is there. Give me enough unmasked data and you can identify anybody. And with all the hacks that go on, Dr. Matthews, you're right. People really shouldn't be that concerned about somebody seeing their, health checkup bill. But what they should be concerned about is that data that does get stolen gets aggregated with their financial data from the bank. It gets aggregated with their, credit card from Target or Home Depot. It gets linked to their Experian credit data and linked to their mobile phone data. All of a sudden, that person has the ability, if they pull that together, to not just impersonate you, but probably be a better version of you online than you think you are. So.
Well, that takes up any of my Instagram or Facebook aspirations of showing my best life. But I'm going to skip over, because we've talked a bit about data sharing and kind of what healthcare provider organizations kind of know about us or what they're able to buy. I want to kind of get to literacy. And, Matthew, one of the things we talked about was patient and provider communication. Mm-hmm. It's always been traditionally kind of the role of caregivers to try to explain healthcare to patients. But when you start getting into personal health information and understanding not just your health, but what's happening with your data, I mean, I as a physician don't feel like I have enough knowledge to have that conversation with my patient, because
absolutely,
to Fred's point, I don't know what happened to the data.
Absolutely. Well, and I have a great anecdote. So I was on vacation a couple weeks ago, and my son had to be taken to the emergency room. Fortunately, it was nothing serious, but the extent of the conversation over where is this data going was limited to me signing a 8.5 by 11 sheet of paper with a lot of very small text saying, "Here's what we're going to do with your data." And it was a hospital I'd never been to before. So this was all new data for them. I honestly have no idea where that data is going to go. And frankly, the doctor was concerned about treating my son. So we had no conversation about that. And as a matter of fact, I'm still trying to figure out how to get that data back to our doctor at home.
Go ahead, Fred.
Matthew, you bring up something really interesting there. There's when we talk about health and PI literacy with patients, so much of what gets absorbed into the healthcare system is still written on a piece of paper. Yeah. And there's this false notion that piece of paper sits back in that old file cabinet forever. It doesn't. It's scanned. It's read, probably not by a person, but probably by a computer system, understands what it is, files that data away, parses it out, and distributes it into, any number of systems. So I think it's important that patients really understand that when they give somebody their personal data, they are giving them their personal data. It doesn't matter what form it's in. Dr. Matthews, I'm sure you as a physician, you take notes after you've been with the patient. There's lots of things that take place there. But I think it's important that when we talk about data ownership there, and data literacy, it's important to kind of instill a sense of digital ethics into what we're doing. And I think it's incumbent upon us in the industry to work hard to make sure that people do understand that their personal data, it's never recovered once it's lost. And they need to take a personal sense of ownership over that data. I've seen too many people that just say, well, everybody has my data. It doesn't matter. It's already out there. It may be out there from yesterday. I'm more concerned about what happens tomorrow, with these people.
Yeah.
Well, and there's also, the challenges around access of that data. I mean, myself as a patient, I really don't have any access to the data that's stored in various EMRs of providers that I've ever visited. Around here, I don't know about the rest of the country, but here in the Chicago area, providers are just now getting to the point where they're willing to work with you through an app on your phone.
Right.
And I can't really see anything except whatever the results of my last visit were. So there's still a lot of friction in the aspect of providers being able to share data even with their own patients. And some of it is regulatory. A lot of it is just technological. I mean, I worked in EMR hosting for 6 years. It's a dirty secret in the industry that EMRs, electronic medical record vendors, are probably about as far behind as you can get in terms of software functionality.
It's fair, though it's funny when you look at some of like the class research in terms of satisfaction for EHRs. Some of them always seem to rank like 10 out of 10, and I'm not sure exactly what.
Who are they surveying?
Yeah, because it wasn't me. Here, let me kind of keep it going. I wanted to ask about when we talk about the threats that are coming and people stealing your data or your identity. This kind of leads to the whole idea of consumer data protection, right? When we think about consumer protection, there's always this almost, I think, fantasy land that people have that there is some entity that is benignly protecting them from all threats, and somehow they believe that it magically applies in hospitals or with doctors. And I obviously just kind of like do one of these and I just shake my head because I'm like, no, that doesn't really exist. But I'm also not on the ground level trying to figure out how to protect it. I mean, what are some of the challenges that we're seeing these days? Fred?
Yeah, the challenges that the healthcare industry, is facing, by and large, with a couple of minor exceptions, they tend to be the same issues that just about every other industry is facing right now. Part of it, has to do with the way technology evolves and gets brought into a system. Mm-hmm. The technology, when it comes in, it usually starts off just as a replacement. I've got something that I'm physically doing. I'm going to replace it with something digital. Once that works, I start to roll it out everywhere. If there's a flaw in that system, and there's always a flaw in the system somewhere, that flaw gets propagated out. Even worse, if you let technology kind of move into the system, and I deal a lot in cybersecurity and digital transformation areas. One of the risks that we see, all too often is that people inject technology, spread the technology, but they're not doing anything to change the process. Right. They're not taking advantage of the efficiencies and the innovation that can come through. It's one thing to automate, a lot of data. It's another to kind of really transform the process that you're going through. But at the end of the day, it's impossible to secure just about any form of data. I like to tell people that if you've got something that's really private and you don't need it anymore, delete it. Because somebody will find that data, and they may not be able to hack it today, but give them a year, give them 2 years, give them, wait until the quantum crypto gear really starts to come into play. They'll hack just about anything. So I think it's important that, as healthcare organizations are injecting technology as they're transforming themselves, I think it's critical that they do a couple of things. First is you always have to recognize that the injection of technology only works when you have the right people, and that includes the cultural aspect around that, but also the right processes that are, tailored for that technology. The process of vetting somebody or confirming a data transfer over the phone 2 or 3 days later, that doesn't fly. Even email, not fast enough to keep pace with this. So if you're injecting tech, the providers across the board, technology, people, and process, you've got to start there. And then also, I think it's important, and I know we've talked about this previously, when you're trying to protect consumer data, you always have to think about the risk potential, somebody's identity, somebody's health record. And you kind of have to get to that point where you ask yourself, yes, I can put this data here. I can blend it with this, but should I? Is there an inherent risk? And if I can't guarantee the security of that data reasonably, don't do it. We were talking blockchain earlier. Blockchain is great. Use it all you want in the back office, but don't blend that with, PII. Don't blend that with some new system that you think is going to provide all these great innovations, and in the end just creeps out the patient.
Right. Makes sense. Matthew, what's your take? No, it does. Matthew, what do you think?
I think it's great to talk about a lot of, it's great to talk about what can be done or what is possible to be done to protect patient data. The real life situation is that there's a lot of provider organizations in the United States that just don't have the money and talent to implement them. In a previous life, when I was working with, doing EMR hosting, we worked with small regional local hospitals that maybe had one or two IT people. They didn't know the first thing about security. And you know what? Those were the first organizations that were likely to get ransomware, that were likely to get virused. One piece of advice I can give is, a lot of providers have financial concerns as well. So this might just be a shameless plug for organizations like yours and mine, Dr. Matthew, but, partner with somebody who is able to provide a security focused service, because a lot of times you just can't do it yourself.
Yep. Matthew, there are a lot of really good managed security providers, MSPs out there. There are a lot of really good hosting companies that can provide this tech. That's a great point. I don't expect the medical profession to be an expert in cybersecurity. Find the right people.
You do what you're good at.
Find the right tools and educate your staff. Phishing attacks occur in just about every industry that I've seen out there. So do we want to mention GDPR here as we talk about consumer data protection?
Sure. I mean, I think that's come up quite a few times when people talk about what Europe is doing, how companies, not only like Facebook and Google, but even some of our healthcare companies are reacting to it. But people have been looking at it, at least as an initial template for how would we protect our data or our health data.
Well, I think despite the challenges that we faced of late, not just with cybersecurity hacks and so forth, but with the disclosure of Facebook activities, Google activities, this consumer second, shareholder first approach. I think that's really gotten us into trouble there. Still, I don't see anything on the horizon that mimics GDPR in the EU coming to the US. But I think there is an opportunity for medical professionals, in fact, just about any industry out there. If you shift your focus and you talk about, we're customer first, we're patient first, we're consumer first. Think about the patient's data from that perspective as well. And, really adopt that mindset that says, patient comes first in all regards, no matter what we're doing. We need to think about the potential impact, the benefit and the risk to the patient. So even if we don't have a GDPR here, we can still follow the regulations. I think they're great. They're a good starting point, but there's a mindset, a cultural mindset that we need to inject into the profession.
It's always possible too that some of the more progressive states, certainly like California or New York State, may wind up implementing some type of GDPR light, in the next 5 to 10 years anyways. And as we know, so as it goes California, typically goes the nation afterwards. So
yeah,
who knows? We may see something like that sooner rather than later.
Matthew, you may see this in your work, but show me a healthcare provider, a pharmaceutical company, a CVS drugstore chain that doesn't have data stored all over the place. And one of the things with GDPR is they're very controlling about, or very strict about where you can actually share somebody's data. If it originates in Europe, you don't ship it to the US. if we do get into that situation where California, as they often do, impose some type of tighter restriction from a regulatory or a policy perspective, that's something that I think it's a reasonable enough chance providers should start thinking about that now. What's our fallback mechanism if that occurs? Do we have a cloud infrastructure that's set up that we can, appropriately segment or firewall off? Can we restrict access to data based on geography within the U.S.? That's, if you don't think about that now, even just as a starting point, when this ultimately does occur, I think, the risk to the operational status is very high.
Again, I don't want to get too off script, but I do think that I always wonder cui bono, who benefits, right? Now, when I look at it from the patient point of view, right? If I knew that someone was taking my data without permission and monetizing it in some way, yeah, I don't think I'd be thrilled about it. And, it always kind of cracks me up sometimes when people are like, it's very complicated. You can't explain it. I think when Napster first came out, I think it was Metallica was really upset that their music was being shared. Do you remember the MTV video where I think it was the drummer? He like pulls out the Coke can from some guy and says, "See, I'm borrowing your Coke can, but it's your Coke can. Hey, I'm borrowing your girlfriend, but it's your girlfriend." The whole concept of it, I think, is very simply, this is mine. You can't have mine without my permission. And I think when it gets complex, when you're talking about people putting legislation through, like even in California, the biggest beneficiaries of having almost like a shadow data market are large tech firms. They don't pay for it, at least pay much for it. There's not a lot of light shined on it. And I don't know how they would react to legislation that forced them to actually talk about it. I mean, even post Cambridge Analytica.
Well, that's why I think they need to be proactive in that regard. I recently did a deep dive into the insurance industry, and the number of times that I heard back to me, we're trying to integrate the supply chain. We're trying to, blockchain for, cold chain storage for drugs. We're trying to see what's on the shelf. We want to keep the medicines fresh. We want to be able to track all the way from the provider that provided that first raw ingredient that made its way into the lab, that made its way into production, made its way into a pill, through the medical facility, through CVS or Walgreens to the patient itself. I mean, they're really working hard to connect, the patient all the way back to create this single source of record for everything. But there's a lot of risk, inherent in that, a tremendous amount of risk. And, to your point, I don't think people realize the amount of data that they give that can spread. It's go to 23andMe, go to ancestry.com. When you give your blood or your saliva in there, buried in that ancestry.com agreement is a little tiny line that says, hey, essentially, we now own your DNA. Yeah. We can do with it what we want. We can sell it. We can aggregate it with others. We can, in fact, at that point, there's a sort of a Gattaca type concern. If you remember the movie Gattaca,
eugenics, sure, yeah,
you're valid or you're an invalid in this case, and your DNA tells more about you than people would ever like to admit.
Yeah.
Now you can play devil's advocate with that as well. I mean, there are two sides to this sword. So if you look at medical records as they stood even 10 years ago or 15 years ago. They were on paper in the back office of, in the back office of your doctor's office. As much as there are certainly, and I don't deny that there are certainly risks to personal information. There's a big data aspect to this too, which is now we're being able to predict, make better diagnoses. There's a lot of analysis that can be done on that data, whereas that data used to just be locked up in a back closet somewhere. It's just whose hands is it in, and who's doing the analysis, and for what purpose are they doing it? That's the frightening part.
The thing. I mean, when we start talking about these type of analyses, like I've been doing this with some of our machine learning algorithm folks, and I always ask about the use case. All right, who's paying for the use case, and what are they trying to accomplish? If I'm a insurance company, especially now post ACA with association plans coming through, unfortunately, I think the priority is, how do I save money first and second and third? Clinical outcomes might be there, but they take a damn long time. And I think, if I'm a drug company, I want to have what are the best outcomes, but there's also the underlying, what is the best revenue model for me? Is it an annuity model where I keep somebody on my treatment for a long period of time? Or is it a one-stop payment, in which case I have to accumulate it all and charge like a hepatitis C drug? So give me 3 years of your salary, because that's what it's going to cost you.
Well, I think there's an analogy there to the insurance industry. If I kind of break them apart for a second, healthcare from insurance providers, the insurance industry is undergoing a pretty fundamental shift where most of the larger providers, they recognize that, whether it's healthcare insurance, whether it's automotive insurance, at the end of the day, most people would much rather not incur the risk event, whether it's an accident, whether it's an illness. They'd like to avoid that because, the alternative that we have today is you incur that catastrophe, the tragedy, you get sick, something is broken, something is lost, and then you have to go through the recovery. I can't think of too many people that when you give them the option of, look, pay us and we'll keep you healthy, or pay us and when you get sick, we'll give you money back. I'll take the first option, every day of the week. And, Matthew, you're spot on, with the amount of information that we can gather, especially when you start talking about, smart tech that is mobile, that goes with the user. I mean, hell, my cell phone tracks more medically about me than any doctor ever will. But all that IoT data, it comes back, it feeds into the system. We can analyze it. We can learn from it through machine learning algorithms. We can predict who's likely to get sick, what this particular outcome may be, and what course of treatment is there. But that's still a lot of, data coming in, cloud magic, something happens, and data coming out for most people.
It's the data exhaust, right? It's what you leave behind that people kind of interpret the tea leaves and figure out what's going on.
Yeah. And at some point we do have to say, what's the ethical thing for us to do with technology? We may be able to extend this or offer a better benefit, but the trade-off is we now capture so much personal data about this individual that, we can't close that door. It's, it's forever open.
Yeah. It's just,
I feel like we left that on a downer.
No. I mean, again, trust me, I was talking to a couple of startups a few weeks ago, and I felt like Debbie Downer after my hour session. They're like, "Wow, this is really hard." I'm like, "Yeah, healthcare has been hard for a long time, guys, but you'll figure it out. You just got to stick with it." I feel like if we were to be constructive about this, right, take something from this in ways I feel is like the beginning of a watershed moment, because you have all these analytics capabilities and people are trying to do these great things, to your point. And there's all this data that's being collected, and we don't know, there's opportunities, right? Just like when somebody figured out that your pulse was related to your heartbeat, or, looking at, your EKG could tell you what's going on with your heart. There might be clues in this new data that's being collected that can tell us things that we don't know. But I do think that you're right. Some type of protections or something has to be put in place to make sure that it prioritizes the patient, or prioritizes the person at the center, and not the industry serving them. And I think, I was talking to somebody yesterday and, had this ridiculous revelation that everybody already knows, which is, why is it when we talk about healthcare providers and businesses in healthcare that the profit motive always wins? And it kind of answers itself. When you are a for-profit company, or even a not-for-profit company to a degree, you do need to grow, and you do need to answer to your shareholders, your equity holders, and that can overlie any type of incentive to try to help patients. And I feel like that happens with managed care, with hospital systems, with provider groups, with pharma companies. I mean, PBMs in my mind are a great example. When they first were conceived, 20, 25 years ago, they really had a mission to try to negotiate good prices. I don't know if you all saw the disclosure from Ohio a few days ago, where they actually had shown either Walgreens or CVS, but they showed that there was almost an 8 to 10x markup of the drug that they had gotten from the pharmaceutical company and sold. They basically discounted it to a degree where they could actually save them so much more money, but they kept the difference. because they're a for-profit company, and their job is to basically make profits. They wedged in there, innovated a new way to kind of be in the business, and then the for-profit motive drove it, and then made them to the point where they're kind of gouging now. And I don't know how we fix it. I feel like it even applies to AI. Without that ethical piece in there, where patients are prioritized, look, my business does this. My use case needs to do this. If I don't prioritize outcomes improving, then that's so be it. I need to make the next quarter. I hope that, I don't know if that sounds right or not, but
no, it does, and I think that gets to the core of putting the patient first. And involve the patient here. There's a lot of education that I think the healthcare industry can do to kind of bring the patient along and really inform them about the data and about the applications and what they can do and what they can't do. So it just drives from a patient first perspective with data.
I think we're down to our last minute or so, if not near the end. I just wanted to leave any closing thoughts for either one of you in terms of what we've said or something we may have missed. Fred, we already have you up on the screen. You want to start? 10 seconds.
Well, 10 seconds. Look, nobody deals with technology alone. If you're a healthcare provider, if you're a pharmaceutical firm, if you're an insurance provider in the medical industry, seek out the right experts, seek out the advice. There are a lot of brilliant people out there that can guide you and help you with a lot of the technology and the process issues along the way. So don't try and do it alone.
Okay, thank you, Matt.
Apart from just seconding what Fred said, can't agree with that statement enough. The only other thing I'd say is buckle up, because it's going to be a wild ride.
I think that's it. Fred, Matthew, thank you so much for being with us today and kind of sharing your knowledge and wisdom. And again, this is George Matthew from DXC Technology signing off. Thank you.
Goodbye.